Hello and welcome to this very exciting AMG webinar on biodegradable stents. My name is George Webster. I'm delighted to be joined by fantastic faculty colleagues both in studio and online. I'm very excited about the next 3 hours because for my sins I've been involved in ERCP for a little bit over 20 years, and during that time there's been very little change in stents. There's been discussion about particular scenarios in which you use metal stents or plastic stents, but essentially the technology has remained the same. Things have now changed, and there is a resurgence in interest in biodegradable stents, both with regards to biliary disease and pancreatic disease, and in the hands not only of endoscopists but also interventional radiologists and surgeons. And so over the next few hours we are delighted to be incorporating expertise and experience in all of these three areas, and with particular reference to two different types of biodegradable stent. And the first part of this webinar will be focusing on the so-called Archimedes stent, which I'm going to say a few words about now, and then later on we'll be talking about the Unity B stent. So first, a couple of technology comments about the Archimedes stent. I suppose the first thing is, why is it called Archimedes? Who was Archimedes? Well, the classics scholars amongst us, which I imagine aren't very many, may already know. The rest of us will need reminding that Archimedes was an engineer and a philosopher 200 years BC, and he developed the so-called Archimedes screw, which was a very clever piece of engineering at that time to move bodies of water up a level without needing buckets and manpower. The Archimedes stents take their name from this spiral structure, but also, and we'll discuss this I'm sure through the afternoon, also alludes to how these stents work, in the sense that these Archimedes stents work by allowing drainage not primarily through the central lumen of the stents, but around the stents, and so hence the technology and hence the name Archimedes. We'll be talking about Archimedes biliary stents and pancreatic stents. The biliary stents come in a wide range of lengths, starting at 40 millimeters, and have either an 8 French or a 10 French diameter, similar to the plastic stents that we use in usual practice at the moment. The particularly interesting and potentially clinically useful aspect of these stents is their degradation. By definition, they are biodegradable. We'll come on to the perhaps very significant clinical merits of that. But what we're able to do in clinical practice is make a judgment as to the period of time over which we need the stent to be provided. There will be scenarios in which we need long patency, and so there is an 11-week degradation period, but also shorter periods, 20 days and 12 days for fast degradation. And through the session we will discuss amongst the expert faculty the scenarios in which you would wish to choose a stent with a short degradation period compared with one with a longer degradation period. Pancreatic stents, similarly, there is a range of lengths. Again, in our present clinical practice, stents between 4 centimetres and 8 centimetres would be the most usual ones we would use. We can debate that and scenarios in which we would want longer stents. And again, these are a 6 French diameter with the same structure and again with similar rates of degradation. So that's a little bit of a background of the technology of these biodegradable stents. And then during the session, we are going to be demonstrating cases in which these have been used, discussing their indications, and also some very interesting preliminary research on their applications. So we're going to be coming to the first presentation of the role of Archimedes biliary stents in just a couple of minutes. Hello and welcome. My name is George Webster. Absolutely delighted to welcome you to this AMG webinar on biodegradable stents. On behalf of my in-studio colleagues Deepak Joshi and Vasan Venkalachapathy. It's great to have everybody here, and we'll also be joined by expert colleagues from around the world. I, for my sins, have been involved in ERCP for a little bit over 20 years, and not much has changed with regards to stents. We have become very familiar with making the choices as to whether we use a plastic stent or a metal stent, and although the indications have evolved over the last 20 years, the technology really hasn't changed a great deal. Well, in fact, over the last few years, that has all changed, and I think it is going to change further with regards to the application and use of biodegradable stents. And so that's going to be the focus over the next few hours. And it is an area that is going to be of interest not to us as endoscopists, but also to interventional radiologists and also to HPB surgeons. And so it's going to be great to get the experience, the views and the opinion of colleagues in all of those areas. We're going to split the webinar into two broad areas, and that is the discussion of the Archimedes stent for biliary and pancreatic disease, and then a little bit later on talk a little bit about the Unity B stent. So I'd like to get things going by just saying a couple of words about the technology perhaps around the Archimedes stent. Now, the classical scholars amongst us, which looking around here, I don't think is my colleagues in the room, will know exactly who Archimedes was. For the rest of us, he was an engineer, an inventor, a philosopher from 200 years BC in Greece. And one of the things he's famous for is the Archimedes screw. Now, this was a very clever piece of engineering that allowed a body of water to be moved uphill without buckets and manpower. Now, the Archimedes stent, as you can see, has a very similar spiral type structure, but also the way it works is also not dissimilar. in that that spiral structure allows fluid to move around the outside of the stent, and so drainage of the Archimedes stent is primarily around the outside rather than through the central lumen of the stent, a little bit similar to the mechanism of drainage with a standard pigtail biliary stent, which drains around the outside of the stent rather than through the lumen. Now, with respect to the biliary stents, there are two diameters, 8 French and 10 French, very similar to the plastic stents that we would select for biliary disease at present. There's a wide range of lengths from 4 centimetres and upwards, and we can discuss the lengths that we would use for particular indications. A really interesting aspect of the Archimedes stents is the degradation profiles, because there will be scenarios, and we will discuss what those scenarios might be, in which what we really want is to maintain patency for probably a couple of months. And those stents, we may wish to choose the 11-week degradation period. There will be other scenarios where we want a shorter degradation period, and so the 12 days or 20 days may be the stents that we choose. And with regards to the pancreatic stents, again, the length of stents, similar to what we use in most of our practice at the moment, 4 centimetres to 8 centimetres, but in fact right up to 17 centimetres, and we can discuss scenarios in which we might look to choose the longer stents. Again, 6 French diameter, we'll discuss during the session, but pretty similar, but basically what we would choose for a non-biodegradable pancreatic stent. And again, with those different rates of degradation. And certainly I'm particularly interested in the fast degrading pancreatic stent, but my colleagues might have a different view on that. Okay, so without too much further discussion, we're going to get straight into clinical experience, and delighted to hear from Vassan of his experience leading a UK study of the role of the Archimedes biodegradability. Okay, so we're going to get things going, and straight to the first topic of discussion.
So thank you very much for the kind invitation. My name is Deepak Joshi. I'm a consultant hepatologist at King's College Hospital in London. And I've been asked to talk to you a little bit about the challenges of standard practice and the potential solutions with using these new biodegradable stents. These are my disclosures. So it's quite often at the time of ERCP, we're faced with the predicament of whether one should stent or not. We have available to us plastic stents, which have been around for a long time. And perhaps in the last 10 to 15 years, we have fully covered metallic stents. And they come with their own pros and cons. Plastic stents are obviously cheaper, but they won't necessarily modify a stricture. And they can get blocked quite quickly as well. With metallic stents, cost is a little bit more. They have better patency, but they can migrate either up the bile duct or out of the bile duct and cause significant problems for patients. And then there's a number of patients where actually, despite our best efforts, we don't want to place a stent because it means that you have to bring them back for another ERCP, another procedure, which sometimes is unsafe potentially if they have comorbidity, or it can be a real sort of inconvenience for the patient as well. So we now have available the Archimedes stent, and we're going to hear a lot about the sort of stent over the next hour or so. And it has a very unique design. So the picture on your left-hand side shows that you get flow of bile or pancreatic juice not only through the stent but also around the stent. And this is the Archimedes screw, the sort of unique design which allows it to function at quite a sort of successful way. Now there's sort of different sizes in terms of French. There's 6 French, which you can see on the sort of top right corner. That has the flange at the end, and obviously it comes in a number of sizes. And then there is the 8 French and 10 French stent as well. The bottom right hand picture is sort of myself when I was about to place a stent. I believe this was an 8 French stent, and they're very easily deployed on essentially a guide wire with a pushing catheter. So there are many uses of the Archimedes stent, and we're going to hear from sort of key sort of leaders in the field about their use endoscopically. We will discuss some of the indications. There's percutaneous use, so interventional radiologists are now using them, and also surgically as well. So at the time of an anastomosis, whether it's a biliary anastomosis or hepatocogeginostomy, for example, these are all possible uses of the stent, which have been demonstrated and I think sort of are being used more and more sort of going forward. But I think as a endoscopist, I think it's my role to concentrate on the endoscopic use of the stent. So at the moment, we use the Archimedes stent, and this is my personal practice, but there's a number of publications as well. Individuals are using them around the time of cholecystectomy. So patients have presented with biliary obstruction. They have their gallbladder intact. You clear the bile duct, but due to sort of the delay now in sort of surgical procedures due to the COVID-19 pandemic, we have been placing sort of a prophylactic biliary stent, which will remain in situ, will maintain sort of the patency of the sphincterotomy, and will allow them as a bridge to their cholecystectomy. We've used them at the time of a bile leak as well. Again, trying to place the stent, and then it means that your patient doesn't need to come back for a repeat ERCP for removal of the stent. For biliary strictures, we've been using them, and personally, I've used them in benign sort of cases predominantly, and with good stricture resolution. And again, a bit like with the bile leak and the sort of pericholecystectomy cases, tend to use the sort of slower degradation stents. I think we're using them more and more now for prophylactic pancreatic duct stenting. These are obviously cases where you are aiming for the bile duct, but you've accessed the pancreatic duct, and a double wire technique means that you want to place a prophylactic pancreatic stent, which will hopefully reduce the risk of pancreatitis for your patient. And in a number of cases, certain centers will place a Archimedes stent post-cholangioscopy to ensure there's good optimal drainage across the major papilla, and certainly in cases where you've been providing or applying EHL therapy or laser therapy to stones, there's a lot of small debris, and it just optimizes the drainage from the major papilla. Now, in my personal practice, I think all of these indications are sort of relevant for both pediatrics and adults. Obviously, perhaps pericholecystectomy is not so relevant, but we certainly use them for our pediatric cases as well. And again, it just highlights the importance and the need that you don't need to bring your patient back for removal of stent. And obviously, in a child, that's far more difficult. Sometimes there are many more logistics that are involved. So I'm going to just sort of show you some of the published data so far. The data on your left-hand side is from Alessandro Rapici's group, published in 2020 in gastrointestinal endoscopy, and showing that there's a number of indications that people have used these stents for, ranging from prevention of post-ERCP pancreatitis, and I will come to that specifically, going down to the treatment of bile duct stenosis in chronic pancreatitis. And you can see there's a number of different types of lengths and diameter stents that they use. And if you look at their sort of technical features of the use of the stent, the loadability was very easy. You place it on the guide wire, then you have to push it up into the position that you are hoping for. And obviously, that's with a pushing catheter. And again, excellent sort of pushability. And then the fluoroscopic visibility can be sort of variable, ranging from fair to excellent. But again, I think when you're delivering the stent, you can see it very easily with no real concerns. So the other group that have published, this is in 53 patients, and you can see again, if we look at the sort of loadability, the pushability, by and large, this is excellent. They used it again in patients with biliary indications, pancreatic indications as well. So really starting to build the confidence and the experience of these stents, meaning that we're using them in our everyday practice. Now, for those who do enteroscopy assisted ERCP, I think these are cases in point where, bringing the patient back for removal of a stent or a plastic stent or a metallic stent can be very difficult. Enteroscopy, uh, sort of related cases, it will take much longer. And again, this is a published series. From Lina Kalayampa's group, 7 patients, a number of different types of strictures. Some of these patients were post-transplant. And again, the overall feeling was that the technical success was very good. There was one case of stent migration, but by and large, they got an excellent outcome. And here's an example. You can see the cholangiogram with a left-sided stricture, which they've gone on to stent very successfully. So I think these are cases in point where you don't want to bring the patient back. And it's very interesting in their abstract, they say, no patient needed a repeat ERCP for removal of stent. So really excellent outcomes. I think where we will be using this more and more and will well become standard of care will be in the sort of prophylactic pancreatic stenting. And it's worth highlighting the ESG guidelines in 2020. They summarize very nicely the risk factors for adverse events into sort of patient, procedural related risk factors. And what's very clear is if we are cannulating the pancreatic duct, and it's a difficult cannulation, and we have a wire in, then we should really be stenting the pancreas. Obviously, this is on top of giving diclofenac or non-steroidals, but the recommendations are very clear. They suggest the use of a short 5 French pancreatic stent, no flange, so the stents then will hopefully fall out. But then you do have to have a look, sort of 5 to 10 days after placement with an X-ray, which you then have to organize. And then if it is still present, then you have to remove it. So the biodegradable stents, you can place them and essentially know very confidently that the stent will, biodegrade as it's sort of indicated. And in these cases, we'll be using the 6 French stents, 4 or 6 centimeters, and feeling very confident that it will do what it says. So that's my very quick introduction. I think the key take-home messages are with the Archimedes stents are that there are evolving indications endoscopically, percutaneously, and surgically as well. It's very easy to deploy. It's on a guide wire with a pushing catheter, and really there's not much sort of difficulty regarding that. And more importantly, I think these stents and the data that we have so far show that these stents are safe, and there's no additional risk or adverse event profile that patients are being put at risk at. So I'm going to stop there and hopefully take some questions. Thank you.
Okay, so welcome back, and great to have Joshi's expert overview of this topic. We're going to move in just a couple of minutes to see a couple of cases demonstrating specifically the use of pancreatic Archimedes. And then we're going to discuss that particular clinical scenario, and then we'll move on to biliary. So for now, we'll go to the first case demonstrating the role of Archimedes stents in pancreatic disease.
Well, you've heard the story about this chap, chronic pancreatitis, with a low bile duct stricture, pancreas divisum, and pancreatic duct stones. We have previously at ERCP looked to remodel the low bile duct stricture with a fully covered mesh metal stent. We have accessed pancreatic duct via the minor papilla, done a minor papilla sphincterotomy, and put in a 5 French single pigtail pancreatic stent. And as you've heard, the aim today is to see if we can carry out therapy for the pancreatic ductal stones.
And initial pancreatogram there shows a dilated pancreatic duct, probably with some filling defects there. Certainly been seen on imaging. Okay, so we're just going in with the spyglass. Again, there's an interesting discussion to be had about means to fragment these stones. They're often very hard stones. We often, yeah, that's good. We often look at the so-called Hounsfield units. Yeah, actually the stone's breaking up quite nicely. We look at the Hounsfield units, which is an assessment on CT of the essentially the density of materials. And our urologists have always said that a stone in their practice that has a Hounsfield unit of greater than 1,000 is very difficult to break up. So we don't need to go too much further here. Okay, I think that's reassuring. Okay, I think we've done pretty well here, but I do think we need to protect the pancreas at the end of that procedure, and so I do want to put in a pancreatic stent. I'm actually here going to use a 6 centimeter biodegradable Archimedes stent into the minor papilla here. Short wire technique. I'm pushing here with the. That's nice. I'm pushing it with the balloon. Yeah, it's got this flange at the end. That's great. And the wire, and yeah, that's a nice result.
talked a little bit about biodegradable stents. Okay, now we need to think about the biliary stent. Okay, and close. Yeah, yeah, good. Okay, inject. Yeah, and just come down. Let's have a look at this stricture. Very good. Look how that stricture was resolved. Okay, so good, interesting case, lots of discussion points, but I think we're done. Thanks so much, everybody.
Okay, so that was a case that I did a little while ago of using the Archimedes pancreatic stent after pancreatic endotherapy. Those of us involved in ERCP recognise that, in fact, the risk of ERCP related pancreatitis is probably lower in a case like that, despite very invasive intervention, than the scenario of a patient perhaps who's got bile duct stones in whom we need to reduce the risk of post-ERCP pancreatitis. So we're now going to go to a case done by Joshi prior to then discussing this interesting topic.
So this is the case I'd like to share with you. This is the use of the Archimedes stent, and the indication here was for prophylactic avoidance of post-ERCP pancreatitis, in that I was placing a prophylactic pancreatic duct stent. So this was a 30-year-old male who's referred to me because of weight loss and jaundice. They normally fit in well, and you can see by the blood test the bilirubin was very raised, and the CA99 was 8. The MRCP performed at the referring hospital demonstrated intrahepatic cholangiopathy, but a dominant stricture of the right side, and this was the target for the ERCP. A slight movement artifact in the first MR cholangiogram, but you can see here quite clearly how dilated the right-sided was. So in this gentleman, unfortunately, I resulted in cannulating the main pancreatic duct with the guide wire, and I decided very early on that I wanted to place a prophylactic pancreatic duct stent and then to move on to the rest of the ERCP. So here you can see the guide wire in the main PD. So I elected to insert a 6 French 4 centimeter Archimedes stent, which had a fast degradation rate. And you can see here the guide wire is in, and slowly I'm advancing the pancreatic stent using a 5 French pushing catheter, and you can see the flanges of the 6 French stent appear, and then I remove the guide wire, and I was successful in placing the pancreatic stent. And then over this, I was successful in cannulating the bile duct. You can see here my cannula at the hilum. I'm injecting and actually going on to complete the therapeutic intent for the CRCP. Now here at the bottom, you can see the 4 centimeter 6 French biodegradable stent, and here the visibility is actually very good. Now in this gentleman, unfortunately post ERCP, they were admitted to their referring hospital sort of 10 days later with subtle signs of cholangitis and abdominal pain, and they did actually perform an abdominal X-ray. You can see here where you'd expect to see the pancreatic stent, that actually it has dissolved and is no longer visible. So an excellent outcome here. So hopefully that's demonstrated very easily the sort of ease of inserting the stent, placing the stent, and allowing you to move on to complete the therapeutic intent of the ERCP. Thank you.
Great. Thanks, Joshi, for that. Really nice case, and a couple of cases certainly in our practice at UCL, we're increasingly looking to use the Archimedes stent for within the pancreas. Just tell us a bit about your present practice and where you would like to be going with this with regards to Archimedes pancreas, and what you think that might bring to the table.
Thanks, George. I would say for prophylactic stenting and therapeutic stenting, where you don't want to necessarily come back, I think it is the way forward. I think the video, the sort of experience from around the world is that it's easy, it's safe, and you can apply. We apply it at King's to our adult populations, but also to our pediatric populations as well. Certain groups of patients where a general anaesthetic or trying to bring them back is so hard. So I think it really opens the door for those patient groups that you don't want to bring back.
Yeah, and I think that it might be worth just reflecting on the policy that we have with regards to pancreatic stents. So not all the attendees on the webinar may be aware and see if you agree with this in your practice. But what we normally do is, if we have, for whatever reason, have put in a non-biodegradable plastic pancreatic stent, then we have to arrange in 2 weeks to bring those patients back for an X-ray, plain abdominal X-ray, to see if the stent has migrated. Now, in 80% of the time, it will have migrated, and then there's nothing further that needs to be done. But in a proportion, 15 to 20%, it hasn't migrated, and then we need them to to come back and have another endoscopy. And I think you're right. I mean, never mind particular things like the pediatric population, but I think as endoscopists we can think that it's quite a trivial thing for the patient to have to change their day, arrange to come all the way into hospital. I'm sure that we all work in specialist referral centres, and many of our patients have come to us from 20, 50, 100 miles away. Yeah. And the logistics around that are tricky. We don't have brilliant mechanisms for being sure that the patient does come back. And over the years, I've certainly seen patients who have, and there's published literature on this, that if you do not remove a non-biodegradable pancreatic stent, then you can very easily run into the areas of pancreatic stricturing and really big long-term problems. And Vassan, it's not a trivial thing having an endoscopy, even if it's just a gastroscopy, to have your stent removed.
Absolutely, it is purely these people who do not turn up for their stent removal. They end up coming back with severe pancreatitis. Yeah. 2 or 3 years down the lane. Yeah. And it is seen as a mistake by the department, and it's a huge governance issue. Yeah. For endoscopy. And also, we are in the biodegradable bile stent study. We did assess how much it takes for the patient to come to the hospital for the stent change. It is being analyzed. It will be published. It takes a huge amount of effort, just not for the patient, the family members too. Yeah. They have to bring them. They have to take a day off, and they lose money in the form of earnings if they are self-employed. Yeah, yeah. And it is. We say it's a single day procedure. For the patient, it is not. It is the day before and the day after too. Yeah, and nearly 3 days.
We all work in the centre of big cities, and certainly where I work, there's not really anywhere to park. A patient coming up for an endoscopy will want sedation in the majority of occasions, so they can't come on their own. Yeah. So that's often 2 train tickets. You can, without living that far from London, you can find that day trip to have a 2-minute endoscopy to pull out a plastic stent can cost you don't know, you know, £100. You know, it's a big implication.
And for the hospital, that's one slot.
Yeah.
That is one
Which could be
slot
used
which is
something else,
for a cancer patient.
For a 2-week wait. Yeah.
Yeah.
Because
absolutely.
it is not going to go in a normal diagnostic list. It is going to come to an ERCP list where we are going to pull out a stent. Even though it's a 10-minute job, it takes up a slot of ERCP which can be used for somebody who is needed.
Yeah. Let's talk briefly about, you know, the traditional use of pancreatic stents and the particular complications one can get from that. Joshua, you know, quite beyond the hassle and the logistics of following the protocol correctly of X-ray, maybe coming back. Have you seen problems over the years with respect to non-biodegradable pancreatic stents?
Yeah, George. I mean, like with any stent, they can migrate. You know, I think.
Let me stop you there.
Go
Let me
on.
stop you there. Pancreatic stents never migrate, do they? They are deployed.
They do. No, they do. You know, obviously pancreatic stents, they are straight, but there are the pigtail stents as well. We've all seen them deployed where they've gone up the duct, certainly in patients with chronic pancreatitis, big dilated main ducts. And you know, you have to go and fish them out.
I accept that if you're using a straight stent, but a pigtail stent, it never migrates.
It
it's
depends.
all, but I mean, it gets back to the point, doesn't it? That the non-biodegradable pancreatic stent is a very unforgiving piece of equipment in the sense that if it migrates proximally into the pancreatic duct, in inverted commas, or if it's deployed proximally, that can be a life-defining issue.
Yeah, and then you're obliged. You have to go back. You have to take it out. It may require. I think in your case, I know you ended up doing, you know, pancreatoscopy for stones, but you might need to do pancreatoscopy, big pancreatic sphincterotomies, or wide enough to let a SPY catheter in, which is 10 French, doesn't come without risk. Yeah. So, you know, these are all important aspects. It takes one to deploy or migrate up the duct, and, you know, they could come back for 3-4 ERCP sessions. So it is huge when it happens.
And we were also just earlier on talking about the decisions around putting stents in or putting pancreatic stents in where it's going to be a hell of a hassle anatomically to go back in and remove a stent. Tell us a bit about that, Bassam.
Well, if they have altered anatomy, or we have got patients who have had bariatric surgeries or hepatic jejunostomies where you cannot reach the duodenum, and they have ERCP either through edge procedure or laparoscopy ERCP, or in Nottingham we go through the PTC port, we do the spyglass, and we clear the duct. In those scenarios, it is really helpful to place these biodegradable stents where you don't need to go back in, because the repeat procedure, even if it is a small procedure, it is going to take the same amount of time and same amount of hassle.
Yeah, and certainly it also, if one is restricted to using non-biodegradable stents in that scenario, you change your decision-making algorithm, don't you?
Absolutely.
And I've certainly been involved in laparoscopic ERCPs in which we know that at the end of the procedure, the surgeon is closing the abdomen, in which, you know, I've found myself taking a decision not to put in a prophylactic pancreatic stent, despite multiple wires in the pancreatic duct and the concern that there's a risk of ERCP pancreatitis. You know, I've decided, no, I'm not going to do what I would normally do, which is put in a non-biodegradable stent, because I'll never get it out again. And this is all in the pre-Archimedes era, and now I would be so much more comfortable in saying, okay, fine, you know, following the same algorithm as we always would, you know, we want to put in a prophylactic stent here, let's let's just get on and use an Archimedes.
Absolutely.
Can I ask about, we've tended over the years to have quoted to patients, based on the evidence, that there's about an 80% chance of the stent migrating and spontaneously. But I've always felt that there are scenarios in which, the stent, even though it's unflanged, this stent is never going to migrate. And I suppose particular scenarios that I would identify would be where you have, for whatever reason, put in a metal stent in the bile duct. Josh, does that, if you're using a non-biodegradable pancreatic stent, does that impact or?
Well, I think, the scenario you described, George, where you've got a metal stent, which is, let's say, fully covered or uncovered, and you've got a prophylactic pancreatic stent in, somebody's going to have to come back and take the prophylactic pancreatic stent out. Can be a little bit trickier. Your view maybe at gastroscopy is a little bit less. Then the question is, do you need somebody who can use a side viewing scope? And I think there's a small risk, but there's always that chance that you might end up pulling both out at the same time by accident. Very unlikely, but it can happen. So again, there've been times where I've certainly seen cases where they've come back for a stent change of their fully covered 3 months later, and the pancreatic stent is still there because the metallic stent is just sort of wedging it in.
And also, again, getting back to the point you made, the quite a frequent scenario in which we put a metal stent in the bile duct is a patient who's got malignant disease, and yet they may still run into problems. The last thing they need is problems related to chronic pancreatitis if they're dealing with their hilar cholangiocarcinoma, and yet to be saying to that patient that they have to come back into hospital unnecessarily in many ways just to have a pancreatic stent pulled out is a real tough ask, I think. So I'm sure we'll come back to pancreatic stents, but I think now is probably a pretty good time to move on and talk about the role of biliary Archimedes stents. And Vassan from Queen's Medical Centre in Nottingham has led the UK trial on the role of biliary Archimedes stents, and so I hope that we can come to your talk and then chat further.
Good evening, everybody. I'm Vassan. I'm one of the HPB physicians working in Nottingham University Hospitals, and I'm going to present the results of the prospective multicenter observational cohort study, which we did to assess the utility of the biodegradable bile duct stent in the drainage of a bile duct. So, ERCP and placement of stent is the first line of management of bile leak, either following cholecystectomy or a liver leak. The incidence of stone migration from gallbladder is anywhere between 3 and 32%. If the cystic duct is under 4 millimeter, then the incidence is 3%. This increases to 32% up to 32% if the cystic duct is greater than 4 millimeter. 1 in 5 of these patients develop symptoms, and this group may benefit from stent insertion after duct clearance. There has been a significant delays in patients undergoing cholecystectomy since COVID crisis. Biodegradable stents may be useful in this group of patients, as they do not need second procedure to remove the stent. So we did a prospective multicenter observational study to assess the utility of biodegradable stent in the drainage of the bile duct. All adult patients were referred for ERCP either for bile leak or for CBD stones with intact gallbladder and fit for cholecystectomy were recruited for the study, and our sample size was 60. 6 centers participated in this throughout UK, and Ireland participated in this study. Nottingham was the host, and King's, Leeds, University College London hospitals, Beaumont Hospital in Ireland, and Newcastle hospitals participated in this study. Our primary objective was to assess the utility of biodegradable bile duct stent in the drainage of bile duct. Our secondary aim was to assess the technical success of the biodegradable stents, clinical success, i.e. complete drainage of the bile duct, quality of life before and after the procedure, complications associated with the procedure, patient-related cost savings, and hospital-related cost savings by insertion of following insertion of biodegradable stents. This is a crowded slide. This shows the schema of the study. Patients were identified when they were referred for ERCP, and when they were vetted for, when the referrals were vetted for ERCP. Then they were approached with the PIS, and on day 0, the baseline information was collected. The quality of life before the procedure was collected on this day, and they did the informed consent both for the study and the procedure, and they had the procedure and stent insertion. On day 1, day 7, day 30, day 60, day 90, and day 180, they had a nurse-led follow-up and follow-up consultation, and during which time they were assessed for complications, any symptoms, and also for quality of life. In addition to this, on day 90 and day 180, they had an abdominal X-ray to assess the degradation of the stent. The stent degradation was first assessed on day 90. The X-rays were centrally reported at Nottingham University Hospitals. The X-rays were anonymized and blinded to the independent radiologist who reported these X-rays. The complete degradation was defined as less than 25% of the stent visible, partial degradation anywhere between 25 and 75% of the stent visible, and no degradation greater than 75% of the stent visible on the abdominal X-ray. The ethical approval was, we received favorable ethical approval from the Health Research Authority and the National Research Ethics Committee, and this trial was registered in the clinicaltrials.gov. The results of the study, we recruited 64 patients, mostly females and mostly Caucasians, and the median age was 67.5 years, and their median ECOG was 1, and roughly 54 patients had CBD stones, and 10 had a bile leak. Of the bile leak, 1 had a CBD stone within the duct, which was the reason for the bile leak. The technical success was 100%. We didn't have any problems in inserting the stent. The clinical success was 96.8%. 62 of 64 patients had good drainage of the bile. The stent deployment was easy in 91% of the patients, and in 6% it was neutral. The visibility of the stent on fluoroscopy was excellent or good in 91% of the patients. The patient discomfort during the procedure, the median discomfort was 1, and the median discomfort in recovery was 1 as well. There was 1 immediate adverse event, which was mild bleeding, which stopped spontaneously. With regards to stent degradation, there was complete degradation in 88% of the patients, and partial degradation in 4%, and no degradation in 8% of the patients. In the 43 patients who had complete degradation, they were discharged at this point, and the rest of the patients had X-ray at day 180, of which 2 of the 4 patients had complete degradation of the stent. One had complete degradation at day 270. This is an image of a complete degradation. As you can see, if you can follow my arrow, you can see the stent do not completely dissolve, but they degrade and break into small pieces, and they spontaneously migrate into the bowel. And this is another image of the stent lying in the duodenum. This is one patient who had partial degradation at 3 months, where the stent is broken, degraded, and it is broken, and it is lying side by side. But at 6 months, you can see only a small portion of the stent was visible, consistent with complete degradation of the stent. Coming on to the quality of life, we did a EQ-5D quality of life questionnaire before and after the procedure. The quality of life was assessed on day 7, day 30, day 60, day 90, and day 180. And as you can see, there was a significant improvement in quality of life from baseline up to 90 days. This was the improved quality of life was sustained up to 90 days. And the same was the case for the pain and also for anxiety. There was a sustained improvement in pain and anxiety scores following the procedure. As you can see, and as anticipated, there was no appreciable difference in either mobility, self-care, or usual activities of the patient. We had few adverse events. The 2 out of 64 had pancreatitis. 1 had mild bleeding secondary to malarial tear. 1 developed cholecystitis, following which the patient had cholecystectomy. The stent migration was there in 3 patients, and 2 patients had a stent failure, and this was in biliary patients. So, in conclusion, the technical success rate was 100% in 100%, and the clinical success rate was 96.8%. There was complete or partial degradation of the stent in 92% of the patients at 3 months. The most important thing is that there was an improved quality of life, pain and anxiety levels for the patient, and this was sustained up to 90 days of follow-up. Coming on to bile leak, 8 out of 10 patients had a successful treatment for the bile leak. 1 had a recurrence of the bile leak between 30 and 60 days. The patient had 2 metal stents to treat this bile leak. 1 had stent failure after 72 hours and required a metal stent. If we take those 8 patients into account, the hospital would roughly save around £11,304 by preventing another procedure. I conclude my talk, and I conclude by acknowledging and thanking my fellow investigators from Nottingham University Hospitals, King's, University College London, Newcastle, Leeds, and Beaumont Hospital. Thank you so much. I'm very happy to take your questions.
That was fantastic. Congratulations, Basan. If nothing more than to get a group of UK endoscopists together to actually do some proper research. and clinically really relevant research. We've discussed the issues about bringing patients back for pancreatic stent removal, but of course the same scenario is often true of biliary disease. One of the sort of two main scenarios you were looking at was biliary leaks and stone disease. Would you see the indications for biliary Archimedes expanding further beyond those areas? Strictures, for example.
Maybe for strictures you can place 1 or 2 stents, and that will work similar to a straight plastic stent. But that is only if we prove that it is a benign stricture. But for biliary indications, you may consider the Unity B. That is got a 1 centimeter diameter, and it will provide the same drainage similar to a covered metal stent, because that is what we aspire for in our stricture patients. And especially in PSC, IgG4 disease, there is an indication, especially if it is higher up. In fact, Joshi has a video of a proximal stricture.
Yeah, so I think, George, and thanks, Vasant, what I'm trying to work out in mind is, can you deploy these stents, and not need to deliver them through the ampulla? If you've got a good sphincterotomy, you've got a stricture in a patient like PSC, can you deploy one at the hilum? I have done it in a couple of patients, and they've done very well, where the debate is always, should we balloon dilate only, or do they need a stent as well in somebody with PSC? I know the data says we should only balloon dilate, but maybe if you want sort of more better stricture resolution over the next 2 weeks, maybe you could place a 6 French stent. So I think it will evolve more and more as we understand, and Vasant's study, we all participated in that. I think congratulations to Vasant, because we did it at the time of COVID as well. This was true. We were in the second wave. Endoscopy services were hit hard, patients were suffering, and we delivered. And Vasant drove that study, and we got it through. So we will await the full results, the paper, and then we can build upon that, I think.
Yeah, and without getting perhaps too much into sort of clinical detail, but you mentioned PSC, primary sclerosing cholangitis, one of the toughest scenarios that we deal with from an ERCP point of view. And of course the DIL Stent 2 study a few years ago now, as always, excellent study from the Dutch teams, comparing balloon dilatation with non-biodegradable plastic stents, and that came out with in fact the study was stopped early, wasn't it, because of increased problems in the stenting group. But we all see patients with PSC who come to us with active cholangitis, and with a dominant biliary stricture. And I'm always very, very, very nervous about sticking, if you like, to the results of DIL Stent 2 and saying, no, data is that we balloon dilate and we don't put a stent in. But, the demonstrable objective response to balloon dilatation in PSC is always disappointing, isn't it? Yeah. You never do a balloon dilatation and say, wow, look at that, that's amazing. You do the dilatation, things collapse down, and just recently I've had a couple of patients with PSC in which I've said, no, I've got to put a stent in here because this patient's got active cholangitis, and I'm not going to send them home having put fluid into their bile duct and potentially made things worse.
I think the other caveat with the DIL Stent study, and it was a very important study and it still stands the test of time, is that a lot of patients had mild PSC. Now, we can argue or discuss what mild PSC is, but patients were Charles-Pugh A or less than, Charles-Pugh 8 and a Mayo score less than 2. So what about in your advanced patients, George, who they're peri-transplant, are you going to leave them without a stent? And I think these are everyday questions we're facing. And like you said, if they've got cholangitis, is balloon dilatation going to cut it enough? I don't know.
Yeah, yeah.
I wonder whether in that scenario a fast degradation stent may be useful, because you dilate and the stent holds the dilatation for a short period, and while allowing the stent stricture to remodel, and the stent dissolves and comes out.
Absolutely.
And we all recognise that it's in that scenario, it's the next 3 or 4 days that probably is the most crucial in terms of cholangitis, isn't it?
Yeah.
So yeah, I think this could really find a role.
And I think the design of the stent, as you said, George, in your introduction, it drains around the stent, not through the stent. So in theory, if you place one into the right and not the left, you still will get drainage from the left. You're not going to occlude it necessarily. Obviously, ideally, you want left and right stents. So I think we'll watch this space and it will evolve the indications.
One technical challenge that I could would wonder about is the deployment of a second stent through a stricture, bearing in mind that the Archimedes spiral structure of the stent, I don't know if either of you had experience of this, but is there a concern that the second stent may sort of catch on the side of the first one, whereas the traditional non-biodegradable stent is obviously smooth, and one can normally slide past it? Do you think there's any reason to suppose that?
It's a valid suggestion, but the end is tapered very close to the wire. But I do agree the screw might catch. But I placed two stents for a cystic duct leak, and I didn't find any difficulty in placing both the stents, but stricture is completely different scenario, and it may be, we do not know how narrow it is going to be.
Now the results you presented are really very impressive, and I wanted to ask about just very briefly before we move on, degradation. Now, people who are my age or even a bit older than me, who remember the story of biodegradable stents, particularly for esophageal disease, may have a negative view of biodegradable stents, particularly with respect to degradation. But the data that we have here is encouraging. Is that right?
Yes. So we assessed the patients for quality of life and for symptoms up to 6 months. So in patients who did not have a degradation or partial degradation, we saw them at 6 months and at 9 months too. Even if the stent was there, it was not causing any overt problems for the patient. They were asymptomatic. That was one positive finding from the study.
Interesting. Okay, listen, we've had well, for me anyway, and I hope for everybody else, a really interesting discussion about the retrograde endoscopic use of Archimedes, biliary and pancreatic stents. One of the interesting things about these stents is their application not for us as endoscopists, but also for our surgical colleagues. And so we are delighted now to move on to the surgical questions. And we're going to start with a presentation from our colleague Krish Menon, senior HPB and liver transplant surgeon from King's, who is joining us remotely, partly because I think he quite literally may be in the operating theatre. So we only choose the people who are active in the field, shall we say. So let's go over to Krish's presentation.
Thank you. Thanks, George, for the very kind introduction. And it's yeah, just unfortunate that I can't be at the studio with you live because I've just got back-to-back transplants on call. So first of all, also nice to see familiar faces. For one, Vas, who's been known for a long time, Joshi, of course, and nice to see Ravi from India. He introduced me to the Bira Blonde, and I've fallen in love with it ever since. So I'm going to talk today about giving you a background on where is the role of the Archimedes stent in pancreatic and surgery and liver transplantation. So it's really covering the background to where you can use this and what is the current evidence that would help us to support the use of these stents. Next slide, please. So if you talk about liver transplantation, it's really about preventing a biliary anastomotic leak. And we all know that there are two aspects to transplantation broadly, the deceased donor transplantation and living donor transplantation. Our experience, primarily in the West, is about, sorry, there's an echo coming. Can you please take the microphone off of somebody else? Of deceased donor liver transplantation, where we've been able to demonstrate the use of the stent, and we presented our video in the technique at the European and African HPB Congress last year. The second place where I think this stent has a real role, and we heard a lot of discussion earlier today with George and his colleagues about the use of the stent in pancreatic surgery. Now, we all know that in a pancreatic duodenectomy, the Achilles heel in the patient's recovery is really a pancreatic leak that determines not only the length of stay in hospital, but also the eventual successful outcome in reducing morbidity. I'm not so sure about the biliary anastomosis in a pancreatic duodenectomy, unless you're dealing with a really non-dilated duct and you want to use a biodegradable stent to reduce your risk of an anastomotic leak. Next slide, please. So if you look at the incidence of bile leak post-liver transplantation, it varies quite significantly and ranges from somewhere around about 2 to 25%. But specifically, if you look at this particular publication that was a systematic review, for living donor liver transplantation, it averages out about 10%. It used to be, I'm sure Ravi will agree, a lot more when living donor transplantation started off. But as people have become more technically skilled, this is significantly reduced. In deceased donor liver transplantation, for all comers, and that includes donors after brain death and donors after cardiac death or circulatory death, you have about a 7.5% overall leak rate. Now, that might be lesser for patients who are undergoing deceased donor liver transplantation in the DBD setting as opposed to the DCD setting. Now, I personally think that the other concern that we can have sometimes is with strictures that can develop either anastomotic or non-anastomotic. And again, there may be a role for the use of these stents, but that's not the remit of today's talk, because that's been covered in the endoscopic approach to dealing with the problem. Next slide, please. So when you get a bile leak, and it's commonly an anastomotic leak, an early leak is always a bad sign. So if you get an early leak, it usually always is technical, and you're probably best going in and fixing it surgically. But what we do know is that the other efficacious way of treating a bile leak in the post-transplant setting has been with ERCP and stent placement, which leads to successful resolution of the leak in over 90% of the cases. And we know just putting a stent across the ampulla and taking the pressure off the system takes care of the leak, and you don't need to do much more. Non-anastomotic leaks usually occur with posterior ducts that have been missed, a cystic duct stump leak or a duct of Luschka. And again, a majority of these are treated by ERCP and biliary stenting, or sometimes you might end up doing a biliary reconstruction. But for me, the philosophy is really about, and we've all heard the old adage, prevention is better than cure. So is there any way that we can make sure that in a high-risk duct, and when we say high-risk duct, it could be small ducts, it could be a discrepant duct, is there a way that you can put a stent across the system which would stay in place to a point where there is a risk of leak is mitigated? Now, for that to happen, we needed a stent that probably degrades itself, or something that is retrievable later after surgery. And that's where I think I use this stent, and I found this to be really useful in the transplant setting in small ducts, where prophylactically you can put the stent in and do your anastomosis over the stent. So do the posterior wall and then do the stent insertion. And Ravi will demonstrate elegantly how this is done in the LDLT and DDLT setting in this video. So I think that's where the role of a Archimedes stent is in liver transplantation. Next slide, please. So if you were to avoid a bile leak, as surgeons, we know the primary thing that we try and focus on is the technique. Okay, there is no replacement for good technique. So biodegradable stent will not take care of poor technique. It's not a substitute for putting stitches in the wrong way and putting a stent across to reduce a leak. What it does is that if you got a duct that's small and you've got a thin-walled bile duct, you put the biodegradable stent, and that actually reduces your risk of getting an anastomotic leak. I find it particularly useful where you've got a duct discrepancy. And as a surgeon in the DDLT setting, if you've got a small to a large versus large to a small, I would always prefer a small to a large. In other words, a small donor duct going into a large recipient duct is fine, because you can close off the recipient duct and do your anastomosis. But if you've got a large donor duct and you've got a small recipient duct, that is very difficult sometimes to handle. Now, in these situations, what you do have is the luxury of putting a biodegradable stent to reduce your chances of leakage. And for me, primarily in these situations, perhaps there is a role for using a biodegradable stent, and it's calling out for a study like Vasan has already shown us elegantly in terms of doing a trial where you compare the use of biodegradable stents versus no stents in DDLT setting. I'm not going to cover LDLT because that's Ravi's expertise, and Ravi is one of the leading authorities in the world on living donor liver transplantation, and I've had the pleasure of knowing him over the past few years. Next slide, please. So the novel technology of the Archimedes stent. Now, what was my feel about when I used it for the first time? For me, the advantage was the ease of use. So it's not a complicated stent to deploy. And the technical aspect of actually deploying a stent during the transplant operation is simple. It's uncomplicated. And as long as you do the back wall and then insert the stent in, it sits beautifully. So for me, the novel technology of Archimedes stent is here to stay in terms of using it in the DDLT setting in liver transplantation. Next slide, please. Now, I'm just going to run through, the video is going to be shown by Ravi. I've concluded by the use of this stent in anecdotal cases. It's technically feasible, it is safe, it's easy to deploy, and for me, the most exciting part is the biodegradable aspect of it, where you don't have to worry once you put the stent in and you've mitigated your bile leak, and you can have the patient go home without any concerns. I think in the first one, we did an abdominal x-ray just to see what's going to happen to the stent. And we use the one that stays for about 11 weeks, which is the best one to use. Next slide, please. Now, for a pancreatic duodenectomy, again, if you look at the risk of an anastomotic leak, it varies depending on which series you look at. But the most respected series, the one that came from Claudio Bassi's group in Verona, where they looked at 3,000 patients, and this was published in the Annals of Surgery, and they concluded that the pancreatic fistula rate was about 22%. So that's not insignificant. Now, of course, a lot of them are by the ISTB grading, low-grade fistulas that would not require much intervention. However, it does prolong your length of stay in hospital. And if you get a fistula that's a high grade, then your risk of mortality does go up. Next slide, please. So as most pancreatic surgeons will tell you, the risk factors for a pancreatic leak in a Whipple's operation are the texture of the pancreas. So if you've got a soft pancreas, you're more concerned that this is a high risk of leakage. The degree of ductal dilatations. In other words, if you've got a duct that's very dilated, you can drive a bus through it, that duct is highly unlikely to leak because you don't need a stent for that. Your anastomosis is going to be much more secure. However, if you've got a small, fragile duct in combination with a soft pancreas, then you are going to be at a higher risk of getting a pancreatic fistula. The vascularity of the pancreas has been talked about a lot, but in my opinion, nowadays that's become less and less important as people have standardized the ways of transecting the pancreas. Of course, in terms of the technique, as we talked about in liver transplantation, a stent does not mitigate for bad technique. Okay, when you use a stent, you have to still use a good anastomotic technique for pancreatic jejunostomy or pancreatic gastrostomy, whichever technique you prefer. It's got to be tension-free. For me, over the years, what's been good to see is a consistent method of your technique. The more consistent you are with your technique of pancreatic jejunostomy, the less likely you're going to run into complications. Now, I heard earlier George talking about migration of stents and plastic stents. As surgeons, we've done the Panasta trial in the UK, where we use stents versus no stents for pancreatic jejunostomy. And one of the problems we had was the ones that we put in stents, they do migrate either into the biliary system or more distally into the pancreas if your duct is dilated. So it is a real problem if you get stent migration and then subsequent pancreatitis as a result of it. So again, the thing that appeals to you is the Archimedes stent in terms of it being biodegradable. And I think it's better in terms of positioning because of the way the stent is structured with a screw technique. So you can actually place the stent and it's going to stay there rather than actually move around. Because commonly, for example, we use at King's a infant feeding tube that's cut to size in terms of the duct diameter. So for me, Archimedes stent in pancreatic duodenectomy can have a role, particularly in small ducts with a friable pancreas. Next slide, please. So if I were to summarize before I hand over the floor to the guys who are going to show the videos and to show you the actual technique and let them speak to the actual steps within the procedure, I would conclude that in liver transplantation in the DDLT setting, the use of an Archimedes stent for preventing biliary leaks is technically safe and feasible. I think we should start off with a pilot study followed by an RCT. Actually, if you look at it from what I've heard today, you may have enough already to actually move straight to an RCT in the CT setting. For a Whipples, I think, again, using a pilot study to actually get some funding to proceed to a feasibility RCT in a multi-center setting, exactly as Vasan has shown, is probably the way forward. Because until you get evidence, again, to move forward with the routine use of stents is going to be challenging. So thank you for organizing this webinar to bring up this exciting subject on the novel technology of an Archimedes stent. And back to you, George, and the team at the studio. Thank you very much for the invitation. Happy to take any questions.
Krish, thank you so much for a fantastic presentation. And as I said a few minutes ago,
I can't hear
very
George,
conscious that you are quite literally not only doing as you say, but doing as you do, and are actively involved in surgery. If you are still with us and have the opportunity, I think it would be very interesting to show a case.
Guys in the studio, I can't hear what they're asking me.
Archimedes stent in surgery.
Hello?
So I just wonder if you're able to do that for us.
Yeah. Briefly, I did hear something. Yeah. George, I didn't hear your question, so please can you repeat what he said?
Well, I was thanking you for a fantastic presentation, and we understand that you do have a short video case of using Archimedes during surgery, and I just wonder if that is available to be shown.
I do not have it to hand because I wasn't prepared for that when I'm using a hospital computer. So I apologize for that.
That's no problem at all. I think we might. I think it is available. We might actually come back to it.
Okay.
But,
you might have it actually. AMG should have it because they should have it with them.
We do have other surgical cases coming along. We're also absolutely delighted to welcome our friend and colleague, Professor Ali Rapici from Milan. Ali, very very good to see you, and other colleagues from around the world. I think that's Ravi Mohanka from Mumbai. Huge pleasure to have you with us, and really a grouping from the endoscopic and the surgical field. You probably have more experience than any in the world of biodegradable Archimedes stents. We would really like, and we will be coming back to the surgical questions in just a minute, but Ali, fantastic as always to have you with us. And I think you've got an endoscopic case using the Archimedes stent to share with us, which of course will lead into further discussions about surgery and where we sit as endoscopists in the road to surgery.
In this meeting today, sorry for joining a little bit late. So I had a previous presentation. I think my cases, they are perfect for the time because there is surgeon there, and we will present two cases if it is allowed, just two brief cases. I will take 1 minute each, and we can open the discussion that made our surgeon happy. So we used to fight a lot with our biliopancreatic surgeon. It's a back and forth discussion on what to do and what not to do. So I'm glad to present the two cases that allowed us to make them happy. So I think you can see my screen. George, you see the screen?
Yeah.
George, can you see? Can you guys see the screen?
Yes.
Okay, so they can hear me?
Yeah.
Okay, good. So this is my first case, was a 52-year-old male with a long history of alcohol abuse, heavy smoker, huge number. He developed over time chronic pancreatitis. He got so many RCPs in another center outside Milano. And at a certain point, the gastroenterologist, they do decide to refer the patient for surgery to our pancreatic center. We have a huge center with huge number of pancreatic surgeries. So this was referred for with a benign indication, just to make jejunal pancreatic duct anastomosis, because they were trying to do ERCP, taking care of this stricture into the pancreatic head, that they decided to send to the surgeons. But just 1 week later, he was consulted by our surgeon. The surgery was planned already. He was admitted to our emergency room for in acute recurrent pancreatitis and on chronic pancreatitis. I think he was still drinking, so he was admitted into the emergency room. He was very, very sick. You know, these guys, when they get acute pancreatitis or chronic pancreatitis, they may become very serious patients. So I got a call in the late evening from my surgeon colleague saying, "Oh, Alec, tomorrow you have to take care of this." And this was I just got the catheter inside the pancreatic duct. That this was the situation, as you see, quite dilated pancreatic duct on above, just a very severe stricture. And of course, amylase, lipase were very high, and the patient was septic as well. So I start thinking what to do in this case. It was a surgical candidate, so potentially in my mind, it was a guy who was going to surgery in a couple of weeks. So this is why I decided to use a plastic stent. I got the feeling that I had to make some dilation. So I first did the dilation of the duct, you see, we dilated until to 4 millimeters. And afterwards, we decided to use the biodegradable stent. So at this point, I got the feeling that pancreatic stent, the usual pancreatic stent, was not big enough. So I introduced a biliary stent into the pancreatic duct. I cannulated again the pancreatic duct, and you see I was able to place two different pancreatic stents into the pancreatic duct. So what is the take-home message of this situation? So there is a very efficient duct drainage, and even though it's a tough situation, you have a lot of flexibility because you can place also bigger biliary stent inside the pancreatic duct. There is no need to repeat endoscopy. And my original thought, if you use a biodegradable, which is much more compatible than traditional metal stent or plastic stent, there is a reduced damage to the pancreatic duct. And this, I think, was good in the just for the opportunity of repeating surgery. And of course, my surgeon was super happy. So the other case is a 68-year-old female was on waiting list for cholecystectomy, but she was referred suddenly for jaundice and abdominal pain. She did a CT scan, and we just diagnosed a stone into the bile duct with a narrowed distal bile duct. So that was the situation. You see, this is a tough situation because you need to remove the stone, you need to treat the stricture, you have to provide safe surgery to the patient. So what we did first mechanical lithotripsy. You see, this is the traditional Olympus Dormia basket for mechanical lithotripsy, and we cleared the duct as much as possible. And you can see here, it took a certain time, and we at the end, oh, sorry. Oh, it's not working. Okay, we placed Archimedes stent. So normally in this situation, we use the stent with the longest biodegradable time in order to provide a long-term patency of the duct. This was the final results. The patient underwent a cholecystectomy, and I think when you are in a challenging situation like this, there is a stricture, there is a stone, the patient is in waiting list for surgery. It's a good solution. There is a lot of flexibility. It's also a good solution to buy time and decide with your surgeon or with your colleagues what to do. It allows for very safe surgery. And again, since these two cases are bridged to surgery, also the other surgeon was happy as well. Thank you so much.
As you say, keeping surgeons happy is one of the most important roles of the a biliary endoscopist, and I can see Ravi Mahanka there nodding. But you know, I think we'd all agree that there certainly are situations over the years in which we as endoscopists can make the surgeons and the patients very, very unhappy, and that includes the scenario you presented a case of a patient with chronic pancreatitis, and we've all had the patient who has a metal stent inserted, gets lost to follow up, and even if this was a fully covered metal stent, by the time they reappear, that stent is embedded, and that can cause all sorts of problems, or even the disastrous scenario of an uncovered metal stent being put in for presumed cancer that isn't cancer. And I just ask Ravi to get the discussions going. Do you see that as a scenario in your practice in which you, from a surgical perspective, are being asked to deal with, dare I say it, the mistakes of the endoscopist, or sometimes the radiologist, with unremovable metal stents that then need to come to surgery?
Yeah, so uncommon, but a very occasional yes. Yeah, so it's very uncommon though.
I think you're just on mute at the moment, Ravi.
No, I can hear him very well.
Oh, okay. No, so it's very uncommon, although it is a possibility and it rarely happens, but it is uncommon.
Yeah, okay. And the other situation that Ali Rapici referred to is that idea of a bridge to surgery. And certainly the common scenario that we all see in our practices is the patient who presents with biliary obstruction. They perhaps have reasonably straightforward stones in the bile duct, but a widely patent cystic duct and a gallbladder full of stones, in which certainly in the UK, and I would imagine in other countries that others may work in, the ideal of having surgery within the next week is often difficult to deliver. And do you, from a surgical perspective, and both Krish and Ravi, I would ask you about this, do you see an attraction of a biodegradable stent that perhaps will degrade over a couple of months in providing that useful window period, allowing you to get the patient to surgery without needing to go round the loop again of further ERCPs for biliary obstruction?
Yeah, absolutely.
Yeah, I think, without a doubt, George, I think...
and Krish, are you able to approach that, the scenario of the patient who, if we put in a traditional plastic, non-biodegradable plastic stent, then after you've taken the gallbladder out or whatever it might be, that patient needs to be coming back into hospital for a further ERCP to remove that stent. Now, the Archimedes biodegradable biliary stent, may provide some alternative to that scenario.
Absolutely. And I think, there is no doubt that nobody wants, added to the cost, added to the patient's procedural anxiety of going through another procedure, clinic time, follow-up time, there's a whole host of economical reasons why this is the simplest way to move forward. It makes absolute clinical and economic sense, particularly where you got hospital beds that are at a premium. You don't want a one-stop almost. You're doing it and you don't worry about it afterwards.
Yeah.
Completely agree.
Okay, that's brilliant. And I think we should move, if we may, back to the focus on surgical practice.
Can I make a comment?
You gave us a wonderful overview, Krish, of scenarios in liver transplantation and Whipple's resection. Now, in the endoscopic practice, we've been talking about the use of non-biodegradable stents versus the Archimedes biodegradable stent. But with regards to surgical anastomoses and surgical leaks, the question, as I understand it, is really between not using a stent or using a biodegradable stent. Am I right in understanding that is the sort of choice you would be presented with at the moment?
Yeah.
The standard of practice currently is not use a stent, but there is, whenever there is a bile leak, you would think that a stent will solve the problem. And then, our previous experience with stents and the ones published in literature is indicative of a higher complication rates when you do use a stent. So therefore, I think this comes in very handy because most of the complications associated with the stent is actually with its removal when we use it during the surgery. So therefore, it make the biodegradable stents come in very handy because they avoid those complications, and therefore, there's a pilot study that we did, and I'm sure we can look at that actually.
Okay,
So I think
that's
George,
very interesting. And the one of the things that we haven't really come on to talk about, and I'd be interesting, Ali, if you might input from the, well, perhaps the Italian practice, but is cost, because the comparator for ERCP practice is between the biodegradable stent and the much cheaper non-biodegradable stent, but the issues around patients coming back for further procedures to remove that stent. But in the setting of liver transplantation or pancreatic surgery, the cost associated with anastomotic leaks must be massive. And so the relative cost, if it prevents a leak of an Archimedes stent, must be a tiny factor in that. I don't know, Ravi or Chris, if you wanted to comment from a surgical perspective, and then be great to have Ali's view as to how one should look at the cost around the Archimedes stent in ERCP practice, for example. So
I think, George, if you can hear me, the first thing I would say is that in terms of stents, biodegradable stents in the transplant setting, there is one aspect where you're going to do it in the transplant itself to mitigate leaks in small ducts. The second important thing is if you get a bile leak and you're treating it post-operatively in the endoscopic setting, there is again an economic advantage of putting in a biodegradable stent. So there is a second area where you can actually explore the use of this in both scenarios. And then there's a stricture. The third one is a stricture in the latter part of the transplant process. But in all of those settings, I think within a trial setting that you're going to design, there has to be a good economic side to it, because the economic argument is so strong in terms of avoiding another endoscopic procedure, and again the readmission rate with pancreatitis, readmission rate with stent complications or stent sepsis, stent blockages, all of these things, we've never looked at it in a detail, isn't it? Patients come in having had in post ERCP bile leak stent, they have cholangitis, they get admitted, they get then discharged, or the stent blocks or the stent slips, and then you put in another one. So I think, in my view, whatever trial design you have in transplantation or in HPB surgery, that economic argument has to be really analyzed in great detail, because that is the strength of it.
That's very, very helpful. We're going to go to Ravi's transplant case in a minute, but Ali, I just wonder if you have a view of the issues around cost and the health economic costs in our practices. Looks as if Ali might be a little bit is frozen there. Okay, well, we may come back to that question, because I think that, maybe in fact I'll turn to Vassan briefly, because I think you've been looking at this as part of the UK study.
So we did this study during the COVID period, and the COVID has thrown a huge amount of chaos into benign surgeries. If you are a transplant center or a cancer center, cholecystectomy takes the lowest priority, and the patients now wait more than 12 months for a cholecystectomy. This is for UK. Even in Europe, the cholecystectomy is getting more and more delayed, and this may be a bridge, and it can be a useful bridge. And what we have shown is, following the procedure, they have a sustained improved quality of life up to 90 days. That is both in pain, anxiety levels, and their overall quality of life. Part of this you can attribute to ERCP, but some you have to attribute to the stent facilitating the drainage and preventing migration of the stones.
Okay, great. That's a great point.
So,
Can
can you hear me now?
Oh, Ali, yeah.
Okay, so sorry,
That's right.
I had
That's fine.
issues with connection. So first, a beautiful discussion, and I agree with all of that. So, couple of points, and I'm glad that surgeons are um, on the board with us to discuss this. What we're doing more and more, patients who are referred with the pancreatic cancer and jaundice, they are expected to undergo chemotherapy before surgery. Now I'm considering to use, I've done a couple of cases with very good results, very good outcome. I'm considering to use, and of course we should have a prospective study with data. I'm using more and more the biodegradable biliary stent, the one with the long-term degradation time, and it works. And I'm so glad because I went to the operating theater and I just looked at one of these patients who was operated on, and the surgeon was happy because he said, "You see what is the difference? There is no impact on the bile duct. The epithelium is not damaged." So I do presume, I'm not sure this is true, and we need to prove this. I presume that the surgeon can have a easier life because they can make a easier anastomosis with less, with a reduction of complication. So with regards to the cost, I'm not concerned about cost, honestly, because I buy stuff that they do work. I do not buy stuff for my patients because they are cheap. So this is a concept that we need to consider all the time. So I know that you are choosing your food, your car, you look for a good balance between cost and quality. So here, the solution that we can provide to our patients based on the technology that we're using is absolutely unique. So even though it's costing more than plastic stent or it's costing equal to a metal stent, I don't think this can be a matter of discussion any longer. And of course, we have done this internally in our hospital. We proved that just not coming back for stent removal for us, it's a really important issue because not only because we reduce the cost of a second ERCP, but we open the space for another patients for another ERCP because I'm sure that after COVID, like you guys in all referral centers, we are obsessed with the patients, with jaundice, with stones, and we do not have time and we do not have space. So just optimizing the turnover of the patients, regardless of the fact that you are saving money from second ERCP, it's a very important point. And we're using these points to discuss with the board. At the end, they do understand. So in general, if I say, okay, I'm driving a Ferrari costs more than a Fiat, but it's much more efficient, it's much more comfortable, and the driver is much happier, I will still using a Ferrari.
Great. Fantastic point that we should be focusing on quality and not cost for our patients. So I think it's a great point. We're now going to move over to Ravi Mohanka's case. So Ravi Mohanka is one of the lead HPB and liver transplant surgeons in the biggest city in, as of yesterday, as I understand, the most populous country in the world. So Ravi is coming to us from Mumbai, and great to have you with us, and really fascinated to see your case and further discussion.
Hi, this is Dr. Ravi Mohanka. This is a video lecture and a brief description of the pilot study we did using Archimedes stents in liver transplant. We know the implications of anastomotic leaks, which is between 5 to 30% in liver transplant, and various stents have been tried to reduce this rate and its associated morbidity and mortality. The problem with using a stent is that it increases the incidence of ascending cholangitis, especially if the stent is across the ampulla. And its removal is also associated with higher complications, mostly associated with the risk of removing the stent itself. So our ideal stent was a trans-anastomotic intraductal absorbable stent, which we found in Archimedes. So we did a pilot study with 20 adult liver transplant patients, 9 disease donor transplants or cadaveric transplants, and 11 living donor transplants in between 2019 and 2020. All were duct-to-duct anastomosis with interrupted PDS with extracorporeal knots. We placed the stent between the posterior and the anterior layers of the anastomosis, and the anastomosis was checked with a methylene blue leak test as well as a cholangiogram after the anastomosis was completed. So the technique is such that we use the stent and we use the anchor of the stent to prevent its migration. We'll first put it in the lower end of the bile duct and then into the graft side of the bile duct, as demonstrated in the video here. So once the bile duct anastomosis is started, the posterior layer is first sewn, and all the knots here, if you notice, are extracorporeal outside the lumen. These are the two corner sutures that are being taken. Once the posterior layer, including the corner sutures, are complete, then we will focus on getting the stent in. And for that, we'll identify the lumen, identify the diameter which is appropriate, the stent diameter, and then introduce the stent into the recipient duct first. This is because the stent is not very flexible. Because of its rigidity, it's difficult to bend it and put it in both lumens. So first we put it in the recipient lumen, bile duct lumen, and then it's slid in the lower direction. And then once it's all the way in, then we'll slide it into the donor duct and then slide it up as much as we can. Because there is only a single flange which is holding its migration downwards, therefore its movement up into the bile duct, into the graft bile duct, is not a problem. Now you see that the stent has been successfully placed and into across the anastomosis, but we ensure, even if we have to cut the stent, that it does not go across the ampulla. After that is done, the anterior layer is taken in a standard fashion using PDS, and you'll notice that we take very thick bites through the anterior wall also, covering the entire hilar plate. This is to reduce the risk of bile leak as well as strictures, and ensures good vascularity of the anastomosis. Now here, some of the important things are that the stent, being a spiral helical structure, it does not block any side branches draining into the bile duct itself where the stent has been put. And that's important because there are several small bile ducts that could be part of your anastomosis. So that's the technique, and all the knots are then tied and the bile duct anastomosis is completed. Now, we've seen that up to 11 weeks, we've found the stents on imaging, either on an X-ray or on a scan, a CT scan. If we don't find a stent after 11 weeks, we assume that it has either absorbed or it has migrated. So the deceased donor were 52 years old on average. The living donors were about 42 years old. Fairly standard profile, demographic profile. The recipients again were about 58 years old with a fairly standard comorbidity profile and a MELD sodium of about 20 on an average. So the operative time, the graft weight, and the anapatic times and cold ischemia time, warm ischemia time were pretty standard. There were not any deviations from most of those transplants we normally do. Here's the biliary anastomosis and stenting data. So 9 disease donor transplants. Obviously, there was single duct in all of them, and then it was anastomosed over a 10 French stent to the single bile duct. In a living donor situation, there were when it was a single duct, which was in 4 cases, we used a single anastomosis over a 6 French stent. When there were 2 graft ducts, which was in 3 patients, we did a single anastomosis over a 6 French stent. There were 2 ducts, but they were far apart. We did 2 separate anastomosis, each having been done over a 6 French stent. And in 2 cases, there were 3 ducts, graft duct, which was anastomosed using 2 anastomoses, each over 1 6 French stent each. So we didn't have any bile leaks, biliomas, or biliary strictures. We had, but this was a short period for strictures to appear, and therefore we make a claim that this we didn't see any bile leaks. One patient had distal migration of stent, which caused ascending cholangitis, which settled after the ERCP guided stent removal. Two patients died, with both of which were unrelated to the biliary anastomosis. One was because of a primary non-function, and second because of multi-drug resistant lung infection. So in summary, we have a very good experience with this pilot study, and the technique is fairly standardized in our unit. I hope that this can be taken up in a larger population. And
Ravi, thank you very much for sharing your outstanding experience. Can I just ask about the scenario of duct-to-duct anastomosis versus hepaticojejunostomy in terms of, because clearly from an endoscopic, we have a very naive view of anastomotic surgery and liver transplantation, in that if you've done a duct-to-duct anastomosis and there's a problem, we get involved, but if there's not, it's our interventional radiologists. Does that have any bearing on your concerns about leaks and the issues around management of those leaks, particularly with regards to the Archimedes stent?
Sure. So the hepaticojejunostomy leaks are actually easier because they will generally settle on their own with time, compared to duct anastomosis, which typically require an intervention. And then even if they don't settle, or even if they do settle, they will form a stricture later. The difference as far as using the stent is concerned, because in a duct-to-duct anastomosis, we have ampulla which is patent. So therefore, the chances of migration is low. Whereas in a hepaticojejunostomy, on the other hand, on the other side, there is like a big loop of jejunum. So the chances of it migrating is really high. So, we haven't really figured out a way to put it in a J yet, but in a duct-to-duct anastomosis, it works really well.
That's really interesting. For the engineers at AMG, could you see a scenario in which some form of proximal flange on the biliary Archimedes stent to prevent distal migration, particularly for the hepaticojejunostomy patients? Is that something that might be attractive?
Yes, in fact, currently there is one flange on each side. So the one that is keeping the stent in place is the one flange on the biliary or the graft side. So if there is more than one on maybe smaller flanges, multiple of them, they may work quite well actually.
Okay, very interesting. Okay, that beautiful presentation and great to have you with us. We're going to move on to another surgical case now from Eduardo Rosso, who I know has been sitting here patiently, and I hope he's still with us. Eduardo is from Turin. Welcome. Thank you for your patience being with us, and I believe you have...
Pleasure.
Thank you so much. And I believe that you have a case of robotic Whipple's resection, or certainly surgical Whipple's using the Archimedes stent, and we would be delighted to see that and then discuss further.
I will show the video. Theoretically, I should have presented a Whipple, but I got a problem with my hard disk that is dead. So I will present another interesting case in which the anastomosis is exactly the same. So I will try to share with you the screen, if they allowed me, or maybe from they can show the video from, well, epigastric pain, as you can see from 3D description was a larger reason portal vein. So in this case, we just by laparoscopy, the pancreas realized to have access to the vein, and we just cut the pancreas to top the portal vein with the stapler, as we do for pancreatic, medium pancreatic resection for tumor, for borderline tumor. Then, as you see, this is the portal vein aneurysm that has been dissected slowly by slowly from the attachment. Usually we mark all the vein to do not get lost during the reconstruction. This is when we do laparoscopic or robotic portal vein resection. It's always the same. Then we clamp the vein and we complete, this is the proximal part of the portal vein. And then we complete the dissection of the vein from the head of the pancreas. Once you have clamped the vein, you have no risk of bleeding, or at least no risk of massive bleeding. So now the aneurysm is almost completely dissected. We just free the posterior part, and then we can resect the aneurysm. You can see now it's completely freed from the upper part and the posterior part. So now we resected the aneurysm. Then sure, because it was a large aneurysm, you cannot stitch and restitch the portal vein directly, because if you do this, then you get an important stenosis of the portal vein. So you will see in a few seconds that after the resection of the aneurysm, we proceed to a patch repair of the portal vein. You see the effect is quite large, so we use Protean suture, and this one is a bovine patch. We can use even a peritoneal patch or falciform patch, but in our experience, bovine patch is much easier to stitch, and then you can cut very easily of the size that you want. It makes things easier for the surgeon. So now we complete the posterior part of the stitching, always under clamping. And now the portal vein is completed, as you can see. Now is the interesting part, the part that concerning the Archimate stent. It was a very high risk pancreas, soft one with a very tiny Wiersum. You see, we tried to put the stent without any help. It was impossible. So we use a endoscopic technique. We just use a wire because the Wiersum was very thin, and we pass the stent through the wire as they do during ERCP, but we did by laparoscopy. It will take a few passage, and then we just need that the stent is inside for 1 or 2 centimeters. It is more than enough to have a protection of the anastomosis. And the fact that the stent is almost larger as the Wiersum, it makes easier the second part, that is the rear anastomosis. This one, you see, is the small bowel. And we use running suture with barbed suture. This kind of suture is not resorbable. It's really changed our life because it makes very easy the stitching of the pancreas. See, in this way, the pancreas is connected at the posterior layer to the small bowel. And then we keep going with the running stitch. I just put 1 or 2, but not to bore you. And this is the last stitch to do the posterior aspect of the anastomosis, to fix it. So now we do a tiny hole, a very tiny one, and then we put the stent inside. To tell you the truth, from this video, we have much evolved. Now we use a completely percutaneous technique. We do not do anymore any hole in the small bowel, and we just use a needle to transperce the intestine, and then we do the percutaneous technique to avoid all this part, and then to make easier the positioning of the stent in the Wirsung. As you see, the hole in the small bowel is very tiny. This is very important because most of the leakage happens because the hole in the small bowel becomes bigger as many sutures you put inside. Most of the time when you try to stitch a small Wirsung, then you increase the hole in the small bowel, and most of the time the leakage is from there. So you can see this is the final anastomosis. Postoperative period was complete and eventual, and you can see nicely the stent well positioned and not migrated. Then we see this patient just 2 weeks ago. This operation has been lasting more than 2 years, and she's doing well with no stenosis of the anastomosis. So we are very happy of this kind of stent.
Fabulous, fabulous video and discussion. Thank you so much for that. Again, myself and Vassan are endoscopists, so we're not as familiar with with the surgical field. But what we certainly know from talking to our pancreatic surgical colleagues is that they always describe that the anastomosis in the pancreatic anastomosis for Whipple's in benign disease can often be more difficult, particularly in a case like this where I presume the pancreas is completely normal, that the ductal anastomosis can be particularly challenging compared with a cancer where you may have a chronically dilated pancreatic duct. Do you see that this the Archimedes stent in pancreatic surgery may have particular applications in benign versus cancer surgery, or do you think that it will find a role in all areas?
I think, as you say, the best application should be really in what we call high-risk pancreatic stump. High risk means soft pancreas with tiny Wirsung, benign disease. These are the best application. But what I think is a plus of the stent is the possibility to do by surgery a kind of percutaneous techniques. Means that we just do the posterior layer, as you have seen, and now in the last very long cases, we are just picking the small bowel from one side to the other, just in front of the Wirsung, and then we pass the stent through the wire. So the size of the small bowel hole is the same as the size of the stent. And you do not put any stitches around, because even if there are very nice video about robotic or laparoscopic anastomosis of the Wirsung, in the real life, most of the time, when you close the stitches, you tire the small bowel, or you make the hole in the small bowel very big, and then there is the risk for fistula. So the application of this stent, I think, is really in the high-risk pancreas. Then surely we do not have any studies, but we have done up to now several cases with good results, because we have got some few leakage, but they were pancreatic pure leakage. Means that low risk leakage. They do not contribute to erosion of the vessels. That is the worst complication that can happen after pancreatic surgery, because then you get hemorrhage, and sometimes patients do not survive. So really, the good thing is rigidity and the possibilities to do a percutaneous approach. Next time I will show you a robotic. I do not have today, sorry for today, but really in robotic is even easier, because you can do all the procedure very easily.
Well, let me tell you, the case you presented was absolutely outstanding, and it's been a huge privilege to have you with us. I'm now going to give huge thanks to yourself, Eduardo, and to Ravi Mahanka and Ali Rapici for being with us for this session. We're going to move in a couple of minutes over to the session on interventional radiology and the role of Archimedes biodegradable stents. But thank you so much for being with us. Fantastic session.
Thank you to you.
Okay, we're changing tack a little bit. We've had a great discussion about the use of AMG, Archimedes, biliary and pancreatic stents in ERCP practice, and we've had a fantastic couple of presentations from our surgical colleagues about surgical practice. We all recognise that within any hepatopancreatic or biliary service, the other crucial element, and we just can't work without them, is the interventional radiologist. It's a huge pleasure for us to welcome Paolo Mara from Bergamo in Italy to tell us about the potential role of biodegradable stents in radiology practice. So thank you for being patient with us, and it's great to have you with us and to hear your presentation, and then we'll have some further discussion.
Okay. Thank you, Dr. Webster, for the invitation. I'm delighted to be here to share with you my experience with biodegradable stents in pediatric liver transplanted patients. So I've recorded the presentation. I'd like to show you now, and so you can put on, and please.
Fantastic.
Thank you for this kind invitation to discuss our experience with biodegradable biliary stents. This radiological imaging shows the typical appearance of hepatico-jejunostomy strictures after pediatric left liver transplantation. On the left, you have a magnetic resonance cholangiography, and on the right, you have another case that shows the stricture at the typical anastomotic site after split liver transplantation. In split left liver graft, the standard management of biliary strictures relies on percutaneous cholangiography, bilioplasty, and the maintenance of an external biliary drainage. However, international consensus lacks on the timing of the external biliary drainage maintenance. Short protocols of percutaneous cholangiography, bilioplasty, and external biliary drainage maintenance have been proposed to reduce the maintenance of the external drainage and improve treatment tolerability. The main advantages of the radiological approach are that it is minimally invasive compared to surgery, and it uses precise real-time imaging to visualize and puncture the biliary tree to avoid complications. However, the drawbacks of the radiological approach are the non-anatomic percutaneous transhepatic access, which is worse, of course, than the endoscopic route, the need for maintenance of an external drainage tube that increase the infectious risk, and the complex management in case of internal stent removal. The revolutionary potential of biodegradable implants are the possibility to avoid the external biliary drainage and so to reduce discomfort and infections, especially in children, to reduce the number of interventions and so to reduce the exposure to ionizing radiation, which is particularly remarkable in children, and to prolong the effect of bilioplasty, so to prolong the survival of the graft. The purpose of our research is to present the preliminary experience with biodegradable biliary stents, which were used as an adjuvant treatment to percutaneous transhepatic cholangiography, bilioplasty, and internal-external biliary drainage to improve the management of biliary strictures after split liver transplantation in children. The Archimedes biodegradable stent has a patented helical design that allows the drainage of fluids both inside and outside of the device. It is made of a compound which is totally biodegradable by hydrolysis in 3 different degradation profiles and different calibers. It is the first one which is CE marked to be used in clinical practice. We started a feasibility study in September 2020 on 6 liver transplanted children with left lateral grafts. We consider only simple anastomotic strictures, and we used just one Archimedes stent placed at the anastomotic site. Stent implantation was performed after a standard cycle of percutaneous cholangiography, bilioplasty, that consisted in a first IR procedure with baseline PTC and first bilioplasty, then maintenance of 1 or 2 months based on tolerance of the external biliary drainage, and then a second interventional radiological procedure to check the results of the first bilioplasty, to perform the second bilioplasty, and then to remove the biliary drainage. At that time, a single Archimedes was placed at the anastomotic stricture site. These are the preliminary results that we obtained with the use of a single transanastomotic Archimedes. We did not have any safety issues, and the low degradation profile that takes 11 weeks at least to dissolve the stent were coherent with the benchmark tests. Unfortunately, on 6 cases, we had 1 case of early stent dislodgement, and during the follow-up, we observed 2 restenosis within 1 year. So we need technical solution to improve the mid and long-term outcomes of this technique. So we developed a new technique called the side-by-side technique, and we decided to use multiple biodegradable stenting in order to achieve larger diameters at the stricture site. So this technique resembles that used in endoscopy, where multiple plastic stents are used simultaneously. We started this new technique in March 22, and we again consider only simple anastomotic strictures, and we placed double Archimedes at the anastomotic site after a standard cycle of treatment with percutaneous cholangiography and bilioplasty. We are now following up 13 patients that were treated, 4 with early Archimedes placement after 2 weeks from the first IR procedure due to concerns about tolerability of the drainage, and 9 cases with Archimedes placement after a standard cycle of treatment, so after 1 or 2 months of external biliary drainage. The primary endpoints of this study are feasibility and safety, and the secondary endpoints are long-term freedom from cholestatic symptoms. So I can show you a typical case and a typical placement procedure of the Archimedes stent. This is the typical appearance of bile duct dilation in a left liver graft in a 3-year-old child that was transplanted due to biliary atresia. As you can see in the pictures, there is a dilation of the intrahepatic biliary ducts. This video shows the percutaneous puncture that is performed under combined ultrasound and fluoroscopic guidance, and as you can see, there is dilation of the intrahepatic biliary ducts without significant passage of contrast media through the anastomotic site. Again, you can see the dilation of the intrahepatic biliary ducts, and there is a tight stricture at the hepaticojejunostomy that was crossed only with a 0.014 guide wire, which is very thin and allows the passage of just small catheters. Then we performed the bilioplasty, and As you can see from the left, there is a tight stricture at the focal notch here, which represent a very short stricture at the hepatic oliginostomy. And this is the picture that shows that the stricture, that the notch was completely one with the high pressure dilation of the balloon. This is the control cholangiography that shows that after bilioplasty, the passage of contrast agent is improved through the anastomosis. And this is the final image where we placed the external drainage that was kept for 1 month. This is the second IR procedure in which we perform a control balloon angioplasty, bilioplasty, in order to check if there is a residual notch, and there is not the case. And this is again a control through the catheter in order to show that the anastomosis is patent, and so there is no residual stenosis. This is the standard treatment for anastomotic stricture, but we want to do something more. So we put 2 guide wires and we placed 2 side-by-side Archimedes biodegradable stents, which are clearly visible here on the final X-ray image. This is the longer one, 6 cm, 10 French slow degrading stent, and this is the shorter one, 4 cm, 10 French slow degrading stent. Why we use so short length of the stent? Because we decide we want to keep the stent just only in the stricture side, at the anastomotic side, and we don't want to push the stent toward the jejunal loop in order to reduce the risk of displacement. Here is an image that shows the final control with a flash of saline through the introducer, and you can see that there is a clear passage of contrast agent through the anastomotic side without stenosis. So the stents provide a clear passage of contrast through the anastomosis. This is the final control at ultrasound that was performed. It was a follow-up control that was performed 2 months after Archimedes placement. As you can see, there are no more dilation of the intrahepatic biliary ducts. And if you see the last image that is coming, we have also the proof that the stents, the biodegradable stents, are still visible at the anastomotic site. So 2 months after placement, perfectly consistent with the benchmark test of degradation. Coming to results, we obtained 100 technical success in a double technique placement, and we did not observe any procedural stent-related complications. For the secondary point on mid and long-term follow-up, the work is in progress, of course. So we used to perform a 72-hour X-ray in order to check that the position of the stent is normal, is correct, and there is no early dislodgement. And then we perform an ultrasound control after 1 or 2 months. This is particularly performed after 11 weeks in order to check the degradation state and the position of the stents. Are there any alternative to the Archimedes biodegradable stent? Of course, yes. There is the LSCS DV stent biliary that was developed many years ago, but it still lacks the CE mark. So it is an expandable stent with a 3 to 6 month degradation profile made of polydioxanone. But the problem is that after 6 to 8 weeks, it loses its radial force and integrity. This experience was performed with the LS stent, and this patient had a colorectal cyst that was submitted to Kasai intervention. Unfortunately, she developed at the age of 6 double stenosis of the biliary ducts at the carrefour. So we had to perform double liver access with a bilioplasty, and then we insert 2 biodegradable self-expandable stent. This is on the right, the ultrasound picture taken 1 month after stent implantation. Another possibility is the recently introduced Qualimed Unity B biodegradable metallic stent. It is a very interesting revolution because it provides the advantage of metal, which has a a more important radial force in order to act against the stricture. But the problem is that not all the degradation profile are available yet due to CE mark pending. So we are waiting the release of the longer degradation profile of this balloon expandable metal stent. Finally, we can use plastic stents, but the problem of these stents is that they are prone to infection and colonization, and there is this wire that should be fixed in the subcutaneous fat of the patient that in some cases may cause problems of infections. Finally, there is the chance to place a cover metallic stent that we use to place in needles, but the problem is that the cover design does not allow for a proper drainage of branch intrahepatic ducts, which is remarkable in small left grafts. And another very important concern is that removal of this type of stent can be very challenging. So in conclusions, the biodegradable stent may significantly improve the interventional radiological management of benign biliary strictures in pediatric patients with liver transplants, who are not eligible for the endoscopic approach, of course. The placement of 2 or more stents with this side-by-side technique is expected to improve the outcomes, overcoming the limitation of the single stent placement. Finally, further technical development is expected in this field, especially for slow degradation profile of balloon expandable metal stents. Thank you very much for your attention.
Thank you so much, Paolo. That was an excellent presentation. We were discussing in the studio, especially when we have tight strictures, whether we can place 2 stents side by side because of the corkscrew nature of the stent. Can you expand a little bit on whether it was difficult or easier to place these stents side by side in a tight stricture?
Initially, I was sure that the caliber of 10 French was adapted only for a single placement of the stent, because I was afraid that 2 stents placed side by side could damage the biliary tree. But that's not the case, because in tight biliary strictures that are fibrotic strictures, we need to reach the most wider caliber, most wider size in order to improve the benefit of stent placement over time. So from the first experience, we learned that the single Archimedes is not effective in the middle and long term, because the strictures tend to relapse. And on the other hand, to answer your question, no, it is not difficult to place 2 stents side by side, because when you have 2 guide wires in place, you can push toward anything. So if you place 2 stents side by side, you can reach a maximum of 7 millimeters of diameters, but it is not on a 3D dimension, but just on a 2D dimension, the 7 millimeter. So you may imagine that the lumen of the hepatocyginostomy has an oval shape, not a round shape. So 2 stents side by side are easily pushable through the guide wires, and we have not difficulties in doing this technique, that we are sure it could improve the long-term efficacy and effectiveness of the bilioplasty.
Thank you so much, Paulo. Do you think, do you have any follow-up data on the remodeling of the structure?
I think that, to be honest, the most important advantage that we earn from the use of biodegradable stents in children is the improved tolerability, the reduce of discomfort, and the infection risk. I'm afraid that we will obtain worse results than we expect from the point of view of effectiveness, because we know that during the endoscopic treatments, the plastic stents are placed for long time, even for 1 year. So now we have just the 11 weeks profile, which is the longer one, but I'm afraid that it is not enough in order to provide a long-term efficacy of bilioplasty. So I think that the advantages of the biodegradable technologies will be more in the field of prophylactic use, surgery, and just to reduce and to improve tolerability of procedures. I'm not sure that we'll get brilliant results in terms of efficacy. We are now following up 14 patients, and we will publish probably the work even when we will have at least 1 year follow-up.
Thank you, Paolo. Do you think there is any role for longer Unity B stents in these scenarios? Because they are developing stents that can last, which can maintain its tensile strength up to 6 months. Do you think those stents can remodel these strictures?
I'm sure, yes. It will be probably the solution.
Thank you so much, Paolo. Following on to this, we will introduce the next session, which will be on the Unity B stents, and George Webster will talk shortly about the technique and the device.
Okay, welcome back, and this is the last session of the day, and we've mentioned the Unity B stent, and we're going to be focusing that over the next few minutes, and we're absolutely delighted to have Professor Rusty Kunda from Brussels with us, and we will be hearing his presentation, but I'm just going to say just a couple of words to introduce the Unity B biodegradable stent, if we can get the slides up on that. Okay, we should have a brief couple of slides to show there. Okay, so still on the theme of biodegradable stents, but moving away from Archimedes. The Archimedes stent in many ways mirrored the plastic stents that we've been using for years. The Unity B in many ways is mimicking the metal stents that we've used over years. You know, we all recognise the merit of having an expandable metal mesh that can not only relieve obstruction, perhaps remodel strictures, and that's something that certainly a single plastic stent has never been able to do. But self-expandable metal stents provide that option. But actually, AMG with the so-called Unity B stent is providing an emerging alternative to the traditional metal stent. And so what this stent includes is a so-called musculoskeletal structure, with the analogy with our own bodies, where the idea of a skeleton, which is magnesium based, which provides the main support structure, I suppose mimicking what we would view as bone, and then the muscle, which is a biodegradable polymer, which supports the overall structure of the skeletal system. And so this Unity B stent, it comes in different lengths, you know, roughly 6 centimeters in length, with different diameters, again, exactly as we find with self-expandable metal stents, 8, 9, 10 millimeters. But then we get to the real merit, and from my perspective, and I'll be fascinated to hear Professor Kunder's view, the really exciting nature of the Unity B stent is its biodegradability. And this can be either over short periods, 1 to 3 months, medium, 3 to 6 months, or a longer period of degradation over 6 months. And we'll move to Rusty Kunder's presentation, but I'm really interested in discussing where this might find a role in our clinical practice in the future. So without further discussion at this stage, I would like to introduce Professor Kunder and hear his presentation, and then we'll have further discussion.
Thank you, George. It's pure delight to be part of this fantastic afternoon and exciting sessions, which I have been following for quite a while. And also I'm of course delighted to be part of it. As Paolo has mentioned, there have been some expandable stents and also larger diameter stents also employed in these indications, and he mentioned ELA stent as one of the alternatives of biodegradable stents. But it kind of didn't live up to expectations, so we were being even more excited to come across Unity B as a completely new concept of metal biodegradable large diameter stent. I have several conflicts of interest to disclose. As George has mentioned already, we are talking about the composite of biodegradable magnesium alloy, which has a special mesh, special pattern and design of this mesh. It's non-covered stent. It's on contrast what we have been using for more than 25 years or 30 years. We can see once again in digestive endoscopy balloon expandable stent. Over the last 30 years, we've been using basically only self-expandable stents. So we are coming kind of back to what we have been doing those decades ago. Except what George has already mentioned, this stent design and its features are very similar to standard self-expandable metal stent. But beyond that, it has certain enhanced features, which we can more or less confirm because it's a biodegradable stent, and by its degradation, it doesn't have gives opportunity to create a biofilm, promote creation of the sludge. It has better crash resistance than standard metal self-expandable stent. ingrowth and outgrowth are minimized because it's a biodegradable, so its exposure is relatively short, but still we need to gather more data about this. And we obviously do not need to remove this stent. There is a limited experience with this type of stent all around the world, and I will talk about some global experience, and I will also talk about our experience in particular here in Brussels. Once again, the stent is loaded on the balloon catheter, so it's not protected when you are inserting it. You have to be very careful when you are passing it through the valve, when you are passing it through the channel. Try to avoid whatsoever contact with the elevator of your duodenoscope if we are talking about endoscopic insertion, because stent can very easy glide. And unless all the other accessories we are using in biliary endoscopy, so we are trying not to use any saline to promote this catheter beforehand. So we're trying to insert it as dry as possible, so the stent will not slide over or glide over this catheter while we are passing it. I would like to show you 3 examples when we decided to deploy this stent. All our cases, and we have done 5 of them so far, are rather complex, with complex anatomy, with surgically altered anatomy. In 2 cases, we have used antegrade approach via US-guided hepatogastrostomy, but I will talk about some other cases. First is a case when we, in November last year, performed pylorus-preserving pancreatodunectomy in modification of traversal longmire for pancreatic head carcinoma. Patient post-operatively was doing rather well, but slowly was developing some slight cholestasis, mild cholestasis, and eventually developed also jaundice with several recurrent episodes of fever, but without any apparent dilation of the intrahepatic bile ducts, and also with a good response on antibiotics. Imaging later on verified very small subhepatic collection without any distinctive mass in the liver hilum. We suspected local recurrence, but we couldn't get any proof despite some biopsies taken that we are dealing with the recurrence. And therefore, in March 2022, so more than half a year after the surgery, we performed ERCP in surgically altered anatomy, where we verified filiform stricture in hepatococcygeostomy, and Unity B stent was inserted. It provided relief and dilated the anastomosis, and it held it patent more than 6 months. However, later on, there was a progression in the hilum mass, and in September 2022, we confirmed that we are dealing with a recurrent disease of this T3 pancreatic head carcinoma, and we performed via stenting in stent technique in this patient, preceded by intraductal RFA. So this is how it looked like following surgery. We have Roux-en-Y reconstruction with pylorus-preserving. We have pylorus-preserving modification of following pancreatic resection, and there is this fluid collection of liver hilum, but without any distinctive mass. We performed ERCP at surgically altered anatomy with a forward viewing endoscope. You can appreciate that anastomosis was found, and we dilated anastomosis with balloon up to 10 millimeter, and then we deployed Unity B stent. You can see immediately that we evacuated also some sludge. I'm doing these surgeries myself, so I'm trying to create anatomy which allows eventually to perform some subsequent interventional endoscopy. Then we inserted Unity B. This is how it looks like. So you can see that there is a basically naked uncovered stent loaded on the balloon catheter. At the end, you may have appreciated radio opaque marker, and then we dilate. diameter of the stent depends on the size of dilation, on the pressure. So there is calibrated balloon which provides very precise dilation and expansion of this stent. Here you can see how it looks like. The stent is fully deployed and expanded by balloon in hepaticojejunostomy. And this is how it looks like following complete dilation. As I mentioned, 6 months later, we confirmed that it's malignancy. Despite there was still good flow, we anticipated progression, and we decided to perform intraductal RFA and perform Y-Hilar stenting. Another very good example where to deploy it is a 70 years old male patient, where in April 2020, in the middle of pandemic, we perform extensive surgery due to bismuth collet 3B cholangiocarcinoma, and we perform biliary reconstruction on non-dilated intrahepatic bile ducts with Roux-en-Y hepaticojejunostomy. Shortly after the surgery, less than 1 month later, we confirmed that there was a disconnection of segments 6 and 8, and therefore we needed to create drainage, which we initially created percutaneously, but we want to internalize, and we do it gradually more and more. We internalize by the means of interventional EUS. So first we created EUS-guided access anastomosis in between stomach and biliary limb of Roux-en-Y anastomosis, and then we reconnected by means of EUS segment 6 and 8 with internal drainage into biliary limb of Roux-en-Y anastomosis. More than 18 months later, however, patient was presented with obstructive jaundice, and we have seen stenosis in surgical hepaticojejunostomy. So now we had endoscopic hepaticojejunostomy for just 2 segments, and the rest of the liver was drained through surgical hepaticojejunostomy. We verified stricture. We still had this access anastomosis with odaxios, and we deployed Unity B stent into hepaticojejunostomy. Patient was also diagnosed with a small focus of recurrent disease, underwent oncological adjuvant treatment in terms of chemoradiotherapy. This focus was distant from hepaticojejunostomy, and following the degradation of the stent, patient didn't require any further intervention, and hepaticojejunostomy is still patent, and patient has completely normalized liver function test. So this is how it looks like. So it's a status post left hemihepatectomy and complete resection of extrahepatic bile ducts. You can perhaps appreciate on a cholangiogram that there is some narrowing and dilation of intrahepatic ducts. This is access anastomosis, where you can see access through from the stomach to biliary limb of Roux-en-Y anastomosis. We cannulated very slim, very tiny hepaticojejunostomy, which was the same caliber as before this surgery, and we deployed 10 millimeter Unity B stent provided in 57 millimeter length. So again, by the calibration, you decide. You can here see there is an access anastomosis in between stomach and biliary limb of Roux-en-Y. And here you can see again this distended biliary stent. It needs to be said that you need quite a good resolution of your fluoroscopy to see all the radio-opaque markers, because stent itself, it's very purely visible. So mostly you rely on the marking on the stent itself, but mainly on the catheter. So stent itself, it's very, very poorly visible, even despite that we have a very good resolution fluoroscopy available for us. And this is how it looks like. Again, you can see here in biliary limb, and you can see this access shortcut or bypass into towards hepaticojejunostomy. In a third case, very shortly, we had 72 years old male patient following left hemihepatectomy for liver metastasis of colorectal cancer. Patient developed post-operative bile leak due to partial segmental disconnection of dorsal ducts in right liver lobe. And endoscopically, we drained ventral ducts because there was also leak by the resection plane. But we also reconnected those disconnected dorsal ducts by means of rendezvous procedure and collaboration with interventional radiologists and with employing also interventional EUS.
We seem to have lost Rusty Kunda for a little bit on his third and final case. Really fantastic discussion there, and hopefully Rusty can be back with us. Vasant, just you have some experience of using the Unity B?
So I placed one Unity B,
okay.
but that was in an altered anatomy. Patient had a benign stricture, but this patient had bariatric surgery, and so we could not access the duodenum. So we went through the PTC. We inserted a 11 French sheet, and through that we introduced a SPY Discover scope.
Yep.
Went there, took biopsies from the stricture again, and then we placed the stent through the liver percutaneously, and as it said,
and it's sorry to stop you. The Rusty may have mentioned it, but the delivery system is what, 8 or 8.5?
It's 8.5
so it's
8
pretty
French
narrow,
catheter.
so
it is pretty narrow. It goes easily across the structure.
Yeah.
But what I could not comment on is the elevator, which
sure.
endoscopically. So we placed that, and it was quite clearly visible on the X-ray after the deployment, and the dilatation was easier as well. But this is all done on a percutaneous technique where you do not have that amount of resistance. I do not know how it will do.
Yeah, he made the interesting point, didn't he, that one's got to be careful going over the bridge of the duodenoscope. Yes. The case you described, the cases he showed us so beautifully, those were all in patients with alternate anatomy, and we discussed earlier the scenario that we simply can't use non-biodegradable stents in these scenarios.
Absolutely.
Because we can't get at them again very easily. And certainly within our multidisciplinary meetings, I'm sure you're the same, our radiologists would love to have the option of putting in a biodegradable, expandable stent, across surgical anastomoses, etc. But we can't do that at the moment, and the patient ends up with, percutaneous transhepatic drain, and then maybe occasional balloon dilatation, and then we take the drain out.
It has got lots of advantages because the cytology acquisition is poor with the PTC technique. So they end up with internal external drain, and they stay in the hospital for a longer duration. And in the end, they place a covered metal stent, or they bite the bullet and do an uncovered metal stent.
Great. Rusty, you're back. We lost you for a few minutes.
I have to apologize for that. I do not know what happened, but nevertheless, I would like to show you very briefly. Thank you for having me back.
Great.
I would like to show you very briefly just this last case, where you can appreciate on the left side drained drained both left and right hepatic ducts, or respectively this is anterior segments and posterior segments. But as you can see on the right side, there is a 50 millimeter long artificially pertubated fistula in between disconnected intrahepatic ducts and common hepatic duct, proximal common hepatic duct. So what we did then, we across that fistula, because we needed to have drained both ventral and dorsal segments, so we decided that we need something which is long lasting. We needed something which would enhance the diameter of this fistula, conventional metal stent wouldn't be an option, because they would create just more fibrosis, and we would also occlude the other bile ducts. So we simply wanted to do something differently. So we then deployed Unity B into those disconnected dorsal segments. And this is how it looked like. Again, you can see here radio-opaque markers. As I mentioned before, they are barely visible, but they are highlighted here with a red arrow. And control cardiogram shows balloon expanded Unity B, verifying also good flow from these segments. And this is how it looked like. Patient later developed pulmonary metastasis and needed also other oncological adjuvant treatment. And like the first patient I have mentioned, again, we then later inserted wire stent by means of stent technique. There have been done also and is ongoing prospective single-arm study on safety and efficacy of Unity B, both in benign and malignant conditions in terms of biliary strictures. The study was counting all to have enrolled 40 patients. All of them are already enrolled. The slow enrollment was particularly due to COVID pandemic, which slowed down partially this study. 12 months follow-up in these patients, which was endpoint, was focusing on adverse events and efficacy in terms of clinical, procedural, and technical success. In total, 39 stents were implanted in 37 patients. In 3 patients, they shown in 2 cases they were not a good candidates, and in 1 patient, the stent was impossible to pass through the stricture. 82.5% had a previous stenting, and 70% of these patients had previously performed some kind of surgery. Average time for self-deployment was pretty much uniform, and it was around 7 minutes. Over 92% were deployed endoscopically. Mean follow-up currently at September 2022 with last update was 9.68 months, and 26 patients out of this group of 40 had already completed study with 12 months follow-up. There were no adverse events and severe adverse events reported directly related to Unity B. There have been, however, some adverse events non-related to Unity B. Clinical success rate defined by bilirubin reduction and reduction of jaundice and itching has been almost 95%, which is pretty high. Quality of life measured by scoring increased from 5.4 up to 9.2 in 12 months. Procedural success by rating device performance was 97.5%, and technical success was in over 95%. As I mentioned, 2 devices were not implanted. 1 couldn't pass the stricture, and 1 device couldn't pass through the previously implanted stent. I apologize again for this glitch when I lost connection. We are very much excited about this technology. The limited data are available globally. That single-arm studies in majority performed by Indian, Hong Kong, and Malaysian centers. But we are very keen to have this stent back in production, and hopefully we can define in future studies which population probably may benefit mostly from this type of novel expandable stent.
Rusty, thank you. Incredibly exciting area, and I think what you've done is beautifully demonstrated how this technology may find a really important role, not only in patients with conventional anatomy. You showed a really nice ERCP there of a patient with the right hepatic stricture, but also in the emerging areas of biliary intervention in altered anatomy, where at the end of the procedure, we really don't want to have to be going back in again if we performed an edge or a difficult DBE or a percutaneous procedure. Your talk has been a fantastic way for us to end what I think has been a really interesting webinar. So we're hugely grateful for you to give up your time and provide us with your expertise, and we're going to be really interested to see these studies when they reach publication. We've now been going for over 3 hours, and we've come to the end. I'm afraid. It's been really fun, really interesting from my point of view, and I hope Vassan you agree to just have the chance to really focus down on an area that is really going to change practice in the coming few years. I'd like to thank everybody, our fantastic faculty, the team at Hub who have helped to put on the meeting, and my colleagues at Gastro Learning, and of course AMG Gastro who are so committed and have been so focused in seeing how the new generation of biodegradable stents will really change practice. Just as we finish, if you are keen to know more about how biodegradable stents may sit within HPB practice, I would like to put a plug for our next big event, which is London Live Endoscopy on December 7th and 8th. You can access it for free wherever you are in the world. We have a specific dedicated symposium on the afternoon London time of Wednesday, December the 7th, in which we will be demonstrating and discussing the role of not only Archimedes biodegradable stents, but also every aspect of diagnostic and interventional HPB endoscopy. We would be really keen to get your feedback on this webinar. I think it provides a great opportunity for us to learn together. If you are interested in going back over topics that we've discussed, perhaps there's bits that you didn't catch at the time or want to see again, certainly some of the cases I'll be looking back over, if nothing else, just to see the brilliance of our endoscopic radiology and surgical colleagues. But if you want to go back and view the meeting again, you can do so straightforwardly through the Gastro Learning platform. But otherwise, huge thanks once again for joining us, and Rusty, once again, many thanks for being with us. And so to everybody, thank you, and have an excellent evening or morning wherever you're joining us from. All the very best. Thank you. Hello, my name is George Webster, and I want to tell you about the London Live Endoscopy course, December 7th and 8th. Registration is free. Now, if you're like me, I love live endoscopy courses, but there are frustrations. The frustration is that you're never quite sure whether the types of procedures that you're involved in are going to happen and when they're going to happen. It's always frustrating that in the middle of an interesting procedure, one has to cut to go to another room, and quite often there isn't really the time to have detailed discussion of the case or demonstration of the equipment that is used. Well, for London Live Endoscopy, we get round that. We have 4 dedicated symposia which allow us to focus on all aspects of diagnostic and interventional endoscopy. We have a superb national and international faculty with us. And to remind you again, registration is completely free. You can look at the program and sign up at our Gastro Learning site. It will be great to have you with us.